and member of UCT Global Surgery. And we've got two really exciting speakers today, both of whom I'm privileged to know personally. And the kind of generalized theme is pain and pain management. So, which is a particular interest of mine, so that's great. So let's move forward. We're expecting kind of two 20-minute lectures and some discussion in between. So first on the bill is Romy. Anisa, shake your head if you're expecting something else, but it's Romy. And Romy is a professor of pain in the Department of Anesthesia and Perioperative Medicine. But more importantly, she is a very important personal mentor of mine. And she has grown me up in pain medicine. Everything I know is because of her. Maybe that's an indictment rather than a recommendation. But I'm personally very, very grateful for Romy's influence on my life and my growth and the lives of a group of patients who flock to the healthcare sector with no other options because they have chronic pain and nobody else knows what to do with them. And Romy does, and she has taught a whole cohort of us what to do for these patients. In terms of academic credentials, well, she's the best brain in pain in Africa, and she's the best brain in pain in Africa in the world. And with that, I hand over to Romy, who is going to be talking to us about surgery for pain. Will it work?
Thanks, Rowan. Now my brain is in pain. So, okay, let's see if we can share some slides here. And make sure I can still see Rowan eating his sandwich while I'm talking to you guys. Awesome. And please do turn your cameras on while I'm talking, because I hate talking to a computer screen without a human being to laugh at my jokes or to exclaim when I get my words tangled up. You know, thank you. I do appreciate that. So surgery for pain, will it work? As this is the global surgery group, I thought it would be interesting to have a conversation, and this is always where the conversation starts. So we need to start with the question about what is pain, and what are we dealing with when we're dealing with pain. So we start with this side of, is this person in pain? Yes, no, don't know. Give me some non-verbals here. You think this person's in pain?
Yes.
Yeah. And her?
No.
And him?
Yes.
Yeah. And this person, are they in pain? Maybe. All right. What about this person with the spondylolisthesis? Are they in pain? Femur? This fractured femur, if they're under anesthetic, are they in pain? Hopefully not. So if you've done your anesthetic properly, you'd hope that they weren't in pain. What about this guy? Is he in pain?
Yes.
Oh my word. Yeah, but how would you know if he's in pain? He would tell you. Okay, so we ask him. So Anisa says he will tell you. We'll ask him, and he says no, not in pain. So we need to take a moment and remind ourselves that pain is about multiple different things. And this is the revised definition of pain, that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And we can spend like an hour just talking about this definition. But the key things to remember about pain, first of all, the pain that our patients bring us is unpleasant. It's not a happy place to live your life when you have pain. The second key thing from this definition is that pain is always sensory and emotional. Nobody is ever having the sensation of pain and happy. Okay, it always has an emotional component to it. And the third key word in this definition is that it's an experience. If pain is an experience, that means that there are multiple variables that contribute to it. Pain is a sensation and emotion, and it is something created by the conscious brain in response to processing of multiple stimuli from the internal and the external environment. And when your brain processes those multiple stimuli, it may come to the conclusion that you're in danger. And if it comes to the conclusion that you're in danger, you will experience pain. Sometimes you'll cut yourself and you don't experience pain. Pain is a complicated thing. It's a construct of the brain in response to threat. And it's a high order somatosensory construct of the conscious brain, which is why we love anesthetics, because we knock it out and then we do not have pain. So let me take you through what I'm talking about here. So this is my gorgeous home down in the South Peninsula. And on the weekends, part of my therapy on the weekends is to go and rip up weeds and invasive aliens out of my garden. And my dog sits and watches the show while I do this. Now, it's not unusual when you're doing this kind of activity to incur some kind of minor tissue damage.
No, I'll leave you.
If we have minor tissue damage like this, so cut my finger, you would expect the nociceptors, the nerves in my peripheral nervous system that are wired to fire in response to potential tissue damage, to fire, right? There's tissue damage. Those nerves need to do something. They're going to send a message. It's going to go along to my spinal cord. From the spinal cord, it's going to go along to my brain. But is this going to be painful? Well, that depends. That depends on multiple variables. That bit of information, nociception, danger in your right index finger, is only part of the equation in my brain that contributes to whether I'm going to experience pain or not. So that message gets to the thalamus, it gets distributed across the cortex. Let's think about where it might go. I'm in the garden. Okay, so it might go to the visual cortex. Anterior cingulate cortex integrates information, checks in visual cortex. Where are we? We're in the garden. Hippocampus, memory. What can you tell me about the garden? Oh, we like the garden. It's a happy space. Cool, we like the garden. Okay, integrating information. Auditory cortex, we're in the garden. What can you tell me? Birds singing. Cool. Hippocampus, birds singing. Yeah, could be good. Tell me more, hippocampus says. Birds, what kind of singing are these birds? Oh, I don't know. Auditory cortex, what kind of birds singing? No, these birds are going ch, 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 ch. Hippocampus, these birds. Oh my God, what the hell is that? Amygdala's kicked in, fear factor. Hippocampus is saying, that kind of bird, that's a danger message. We don't like this. This isn't a good thing. Oh, shit. What's going on? Danger, danger. Maybe. Visual cortex, what can you see? I can see this. That's why the birds are making that noise. Not so dangerous. Not so dangerous. Mole snake. You might have cut your finger. Not so dangerous. No pain. Not an issue. Or visual cortex says, don't look, Anisa. Puff adder. Don't like puff adder. Dangerous. Cut finger. Painful. Okay, it's safe. The snake has gone. Whether or not I experience pain from that cut on my finger is not just about the cut on my finger. It's about what else is going on in my environment. What's my memory? What are the other things that I've been through in my life? How dangerous is the current situation that I am in? If my brain comes to the conclusion that it's not that dangerous, I might not even notice that I've cut my finger until I get into the shower later and it stings and I notice blood. Or I go inside and somebody says, you're bleeding, and then I look at it and then it stings. Haven't you ever had that experience of it's not sore and then you look at it and you see the blood and now it's sore? What? How is that possible? Well, now your brain's got additional information that maybe there's something dangerous going on, and then your brain generates the experience of pain. No brain, no pain. When you're treating someone with pain, you are treating a person. You have to engage with them. That means you have to think about their brain, who they are, and all that beautiful complexity. Think about how to engage with this person. Treating pain does not equate to treating nociception. Nociception is activity in the nervous system, peripheral and central nervous system, at an unconscious level, and it's activity about potential tissue damage. But nociception and pain are two different things. Pain is a construct of my brain. Now, why is this important in terms of surgery? It's important in terms of surgery because if we're going to be successful at treating pain, we cannot just target nociception. And I love this slide, and it's the second time I've used it today. I was teaching the fourth year medical students just now. We were going through this. If you only target nociception, it is entirely possible that your pain treatment will fail. To be effective at treating pain, you need to think about culture and psychological factors and beliefs, and not just religious beliefs, but beliefs about what I think is wrong with my body and that my spine is crumbling and that my bones are collapsing or that I've got cancer. Other comorbidities, my personality, my social factors, what else is going on in my life. To be effective at treating any kind of pain, we have to target all of these variables, because all of these variables contribute to my brain having a bit of a meltdown and coming to the conclusion that I'm in danger, generating a very real experience of pain with the purpose of motivating me to change my behavior to protect myself or to get help and heal and recover. So if we're going to treat pain, we've got to think big. So if we look at this X-ray, is this person in pain? Yes, no, maybe, probably, don't know. So this is somebody, this would be classified as stage 4 osteoarthritis. 30% of people with X-rays like this have never had any pain. So how would we know if this person was in pain? We have to ask them. Only way of knowing is to ask them. And it's entirely possible to have really, really horrible X-rays and imaging and never to have had any pain. Because pain is about more than just nociception. Is it likely that the nociceptors are firing in this knee? Sure. But my brain might get that information and go, don't worry about it. Your muscles are strong, doing everything you want to do. Life's good, not a stress. You know, they crunch and creak a little bit, but what's the big deal? And you might actually not have pain. But let's say they did have pain. This person's come to us, terrible knee pain. We've X-rayed them. Oh, nasty osteoarthritis, bone on bone. How would we classify their pain? Well, we need to think about pain beyond just pain. We can classify pain as acute pain or chronic pain. Useful, but only useful if we think about time-based classifications in terms of tissue healing times. The reason why we talk about acute pain as being pain that lasts usually around 6 weeks, but a maximum of 3 months, is that that's the length of tissue healing time. Remember this? First phase of healing, your inflammatory phase, 72 hours to 10 days, 2 weeks or so. Then you move into tissue regeneration phase, which lasts about 6 weeks. You guys know this. If you're watching a rugby match and a player's injured, your friends say to you, how long is it going to be before he's back on the field? And you go, 6 weeks. It'll be 6 weeks. That's tissue healing time. Stage 3 of healing, 3 months. By the end of 3 months, most tissues have healed. Most things have healed by 3 months. Even a slipped disc, guys, has healed by 3 months. So Acute pain is normal pain. Chronic pain, pain present on most days for 3 months, for more than 3 months, is not normal. It's maladaptive. It's unhelpful. It's continuing despite the fact that tissue healing has occurred and that original stimulus has ceased. So that's why it's useful to think acute and chronic, because it makes you think about the underlying physiology. But to really get you to think about the underlying physiology, I want you to think about mechanism-based classifications of pain. Nociceptive pain, normal, healthy pain. When you have a burn like this, we're going to have pain arising because of actual tissue damage to non-neural tissue, and the nociceptors are going to be firing. It's going to hurt. It's helpful. I'm going to protect it, allow it to heal. It's a useful event. As opposed to neuropathic pain, painful diabetic neuropathy, going into the sea like this for somebody with that condition is agony, because there's lesion or disease of the somatosensory nervous system with upregulation of those nerves, increased expression of neurotransmitters and receptors, spontaneous pain, not a pleasant sensation, and unhelpful pain. Unhelpful for me to have pain in my feet and want to protect them and look after them, when protecting them and looking after them doesn't actually help them heal. And then nociplastic pain. Nociplastic pain, pain that arises because of altered plasticity in the nociceptive system. No lesion or disease, no tissue damage. Here, the pain system, the warning alarm system has become so sensitive that now things that really are not dangerous are painful. So if we come back to this arthritic knee, you might be tempted to classify it as a chronic nociceptive pain. Chronic because it's been going on for a long time, but nociceptive because the nerves in this area are firing because of the tissue damage that you can clearly see on the X-ray. But a large proportion of these patients' pain is not nociceptive, it is nociplastic, because that stimulus has been going on for such a long time that their nervous systems are now upregulated. And so their pain is no longer about danger messages coming in from their knee. Their pain is because their whole nervous system has become sensitized. So the question is surgery always effective for pain? Well, it depends. It may be very effective for nociceptive pain, but it's disappointing for nociplastic pain. You've got to assess the mechanisms of the patient's pain before deciding whether surgery is going to be appropriate. And we now have a large body of evidence that total knee arthroplasty for painful osteoarthritic knees is disappointing, because most of these patients have nociplastic pain. And we can assess for nociplastic pain with two very simple clinical tools. One is this questionnaire called the Central Sensitization Inventory that asks patients about a wide-ranging collection of symptoms that tell us that their central nervous system is upregulated. And a score of 40 or higher indicates that they have nociplastic pain and that they will not be good candidates for a joint replacement until their nociplastic pain is addressed. Another assessment that we can do is sensitivities for physical activity, because when people have nociplastic pain, their descending noxious inhibitory mechanisms are impaired. How do we assess for that? We get a pressure algometer, we assess pressure pain threshold, not on their arthritic knee, on another part of their anatomy. We do a 6-minute walk test or a 6-minute sit to stand test and get them a little bit of out of breath and a little bit sweaty. And then we repeat the pressure pain threshold. In somebody without nociplastic pain, hopefully everybody in this room, after that 6-minute walk test, your pressure pain threshold would be higher. You would tolerate more pressure without it being painful, because your endogenous systems would kick in. You'd have endogenous opioids, serotonin, dopamine, you'd feel good, and you would tolerate more pain. In patients with nociplastic pain, their pressure pain threshold goes down after a 6-minute exertion or after exercise, telling us that the descending noxious inhibitory control, DNIC, is impaired, and actually they have descending facilitation. They will not respond well to having a joint replacement because it is not the nociception from that joint that is driving their pain. Their pain is being driven by nociplastic changes in the brain. When patients with nociplastic pain have surgery to address their pain, they require more analgesia. They have poor response to that postoperative analgesia. They take longer to recovery. They have poorer outcomes. And people who have nociplastic knee pain with arthritis, who have a knee arthroplasty, 2 years later report that their pain is no better, despite the fact that they have a perfectly good joint. So will this person benefit from a total knee arthroplasty, which is primarily done because of pain? It depends. If their pain is nociceptive, yes. If their pain is nociplastic, no. The nociplastic pain needs to be treated first, and then they need to be reevaluated to see whether nociception is a driver of their pain and then the arthroplasty would be appropriate. So, is surgery appropriate for pain? It depends.
Thank you, Romy. So we've got 5 minutes to the halfway mark. Are there any? Okay. Do the orthopods know this? First question. Romy, maybe you could give us a feel for where we are in the kind of medical literature and clinician behavior space, decision-making space around this book.
So yeah, so I think it's not just the orthopods who need to know this, but the patients who need to know this and understand this. And I think that's the real challenge. I think the orthopedic world is certainly growing in leaps and bounds in their understanding of this. I think the challenges are that in orthopedics, and I'm a physio, hey, and my background's in sports injuries before I got into pain stuff. So I understand how we can be very driven on biomechanics, driving our clinical reasoning and our decision-making processes. So with orthopedics, it's kind of, I have to admit that I slept through most of my neuro lectures as an undergraduate, you know, like neuro wasn't my thing. I wanted to do musculoskeletal stuff. Now you want me to talk about neuro. It's not my thing. It's difficult to integrate it into your clinical reasoning. But the orthopedics, they're getting there. They're developing an understanding. The challenge is that you have to change your behavior, but then you have to also think about how to engage with patients and help patients to understand this. Because I've got arthritis in my knee, it clicks and crunches, and it's painful, and the x-ray, and you said it's bone on bone. So give me a new knee. That's society's understanding of it. So helping patients to understand that pain's a bit more complicated than that is also a challenge. And often, you know, we go with, oh, well, you know, you insist on the surgery, so let's do the joint replacement. So it's challenging. It's really challenging.
Yeah, because I was going to say, it's not news that patients want to hear.
No.
Because it often comes across as, you're telling me the pain's all in my mind, in my head, but actually on the x-ray, I can see that my knee's damaged.
Yeah.
And I suppose all patients who present with nociceptive knee pain, I mean, I imagine they all develop some element of nociplastic pain eventually. Is that true, or am I making that?
Not eventually. So let's say this: we all have the potential to develop nociplastic pain, not just the patients, us. We can all become sensitized. the fascinating thing is to look at where the research is going at the moment is who are the people who have nociceptive knee pain and horrible knees like that X-ray, but don't develop nociplastic pain? What are the resiliency factors? What allows them to not go down that road of becoming super sensitized? So we know the things that make people vulnerable to develop nociplastic pain: early life trauma, being a woman, low levels of education, poverty, stress, post-traumatic stress, you know, all of those issues. But the really interesting thing is, what are the resiliency factors? What are the things that help to protect people from developing that kind of pain? And I think that's really where we need to start engaging a bit more in our conversations with our patients of not why has this happened to me, but you're an amazing human being. What are the skills and the resources that you have to cope, to build resilience, to recover from the sensitization of the system? The other thing that's wonderful about this term, nociplastic, is that word plastic. It's plastic. It can change. It's not irreversible. It can change. If it changed in one way, it can change back again. There's hope in this. So it's not oh, this is all in your head, you poor sucker, this is it, you know, it's your fault that this has happened. The system's plastic, it's sensitive, life's tough, it can happen to all of us, but you know what? We all have resiliency factors. How can we build your resilience? How can we reduce your sensitivity and reverse that? But the key thing is to do a joint replacement in somebody whose nervous system is sensitized. Not a great idea.
Okay. Thanks, Romy. I'm now, you know, I've got some patella tendon pain, and I'm furiously counting the weeks since the pain started and trying to do some tick boxes in my head about whether this is nociceptive, nociplastic, should have healed, shouldn't have healed. Is it in my mind? Is it still my knee? But Romy, thank you so much for your time and effort. We're going to hand over to Anisa now. If you can stay on, I'm sure there'll be some questions that we can answer each other together. If you can't, understood. And
Rowan, can you allow me to share? Sorry, I'm struggling here.
Can I allow you to share? Amy, can you allow Anisa to share? Because I don't think I'm the official host.
Let me try. I just want to see. I wanted to see if I could pass it on.
Romy, you
I just had it. It was just there. I don't know. Up there next to the leave button, Anisa, there's a little like square.
No, yeah. So before I was clicking on it and nothing was happening. So
okay, I stopped sharing. I shouldn't be blocking you.
Anisa, do you want to send your presentation to me quickly?
Hold on 1 second. Let's just check what's going on. There we go.
Yay!
Okay, we've got you.
Gotcha.
So I think someone needed to stop, so all is good.
Okay, so Anisa is a specialist pediatric anaesthetist at Red Cross War Memorial Children's Hospital with special interests in regional anesthesia, pain medicine, transplant anesthesia, simulation, patient safety. That's enough interests now, Anisa, come on. And she's committed to outreach to improve access to safe pediatric anesthesia and pediatric pain management. So she's currently the president of the Pediatric Anesthesia Community of South Africa, and lots of other things. Amazing. Anisa's also a classmate of mine, and you know, one of those people where I look and go, "What have I done with my life?" So, Anisa, thanks so much for your presentation today. We're really looking forward to it, and looking forward to some insights. I hand over to you.
Cool. Thank you. I just want to confirm that you can't see my presenter view.
At the moment, I cannot see your presenter view.
But you can see my slides.
I can see your slides.
Awesome. Thank you. Okay, that's winning. All right. So good afternoon to everybody. Thank you for listening. And Romy's definitely a tough act to follow. So thanks so much to the organizers for making me follow Romy. That's going to be great fun. But yeah, so today I'd like to share some of our experiences at Red Cross, the Red Cross War Memorial Children's Hospital, where I work as an anesthetist and where I work in the acute pain team. And so just to share some of our experiences in acute pain management, which I think is fairly different from where Romy works, or the sphere that Romy interacts in. So I'm sure most of you know Red Cross is an academic referral hospital in urban Cape Town. It has 283 beds and provides both tertiary and quaternary services for children under 13 in the region. Now, despite the fact that South African population has almost 40% of people under the age of 18, Red Cross is one of only 2 dedicated children's hospitals in the country. And our team there, we perform around 10,000 anesthetics annually, and this is for a wide range of diagnostic and therapeutic procedures. I'd like to introduce you to our acute pain team. So there's myself and another specialist anesthetist colleague, Dr. Kwati Bester. And then we also have a feather in our cap, who's Linda Ann O'Flaherty, and she's a therapeutic aromatherapist who's been part of the team for decades now. She's self-funded, so she raises her own funding, and she's trained a team of volunteers who also help out, and she's on site around 3 days a week. More recently, we co-opted Dr. Asma Salu, who is a pediatric intensivist in the ICU, and also the newly appointed pediatric surgeon, Dr. Tozama Siotula. But I also wish to acknowledge here our colleagues in allied health, so particularly our physiotherapists and occupational therapists. And they are passionate advocates for their patients. They give us valuable feedback about regional anesthesia techniques in burns, for example, and even go so far so as to request patient-controlled analgesia devices to help for mobilizing their patients for their physio. Now, notably absent here is the presence of a pain nurse, and our pain nurse resigned at the end of last year for a promotion, but pain services, particularly acute pain services, are usually nurse-led, and so we miss her quite acutely. And I'd just like to contrast that with some just by showing you what other pain services in other reputable children's hospitals in other parts of the world look like. And I think it's fairly obvious to appreciate here that there's there's quite a significant difference in the human resources that we have. So they have quite a lot of physicians, that includes psychiatry. They've got quite a lot of dedicated pain nurse specialists, also psychologists, physical therapists, and even research and administrative assistants. And none of these children's hospitals serves any bigger population than we do. So I just wanted to I'm not comparing apples with oranges, for example. And this speaks directly to the healthcare workforce crisis in South Africa, but also to the lack of funding specifically for pain services. So the reality, though, is that we work within such an interesting and stimulating environment, and we are fortunate to be exposed to quite a wide spectrum of pathology, due to this quadruple burden of disease in South Africa. Most of the patients that we see in the acute pain service are post-surgical patients, but that's not because there's less of a need with medical patients or less of a need on the medical wards. Unfortunately, we lack the capacity to provide a more extensive service, but we do occasionally see some of their patients, often in quite severe pain with quite significant analgesic requirements. But with trauma or with surgery, pain is usually implied or inherent, and it's fairly obvious. And so those patients do tend to receive more attention, or their pain receives a bit more attention. And just to pull out some of the numbers here, last year, so in the year 2021, we received around 347 patients referred to the pain service or the acute pain service, and almost half of them had laparotomies. Now, we know laparotomies are quite a painful operation. And also I've taken out some other numbers here. So what this chart doesn't necessarily represent is our burns pain burden. And so few patients are referred to the pain team from the burns service, but that's just because our team is so good the burns team are so good at managing their patients' pain, that they really only refer the patients that they struggle with. But to note that Red Cross is a major burns referral center, and last year alone, we admitted over 530 patients to the burns unit. But I thought the best way to demonstrate some of the challenges or some of the experiences we have with our patients is by telling you some of these stories. And this patient, I think, illustrates really nicely what Romy was speaking to in terms of pain, not just being around nociception, but also around emotional and psychological and other experiences. And last year, so this is a boy who was referred by the orthopedic team last year, and he's 5 years old, and he sustained a gunshot wound to his right leg. He was sitting in his lounge, and through the window came a stray bullet and hit him in the leg. And he had a hairline fracture, which was missed, unfortunately, and then he represented with pain about 2 weeks after that. The orthopedic surgeons then initiated simple analgesia and a weak opiate, which is Tilidine. But his pain was uncontrolled, and so he was referred to us. So myself and the pain nurse went to see him, and he was accompanied by his mother, and he was so anxious. He was a bit tearful, and using a developmentally appropriate pain tool, I assessed him to be in moderate pain. But on further exploration, I mean, it took just a few minutes to sit and have a chat. We understood from his mother that every night they hear gunshots and the family huddles together and prays. And this is where they live. This is in their home. And so this child wasn't really experiencing post-traumatic stress disorder. He was repeatedly traumatized on a daily basis. And really, mom was quite frustrated because she just felt she couldn't provide the right environment for her child. So in addition to adjusting his analgesics, so we added something that provided both analgesia and anxiolysis, and we escalated his Tilidine to morphine. We also referred him to the social worker and to the psychologist, who counseled him extensively. But the reality is that we were unable to change his environment. And so I escalated this case to the Child Commissioner for the Western Cape via email, and I've yet to hear back. And I think what this case demonstrates is really the significant trauma that our patients are subject to, not just physical trauma, but also psychological trauma, and the frustrations that we encounter in terms of the lack of accountability of government services to citizens. Our next patient, and this is a picture of her here with her mom, and this is posted with her permission. She was a 12-year-old girl who sustained significant flame burns to her face, her torso, and her legs. And this happened when her home burned down while she was cooking. She had a significant inhalational injury, and so she was intubated and admitted to the ICU, where she spent 12 days. When she awoke, she learned that her younger sibling had demised in the fire, and both her legs had been amputated. She underwent 13 surgical procedures, which excludes dressing changes, during her 5 months in hospital. And this case scenario really just demonstrates the extensive interdisciplinary team collaboration that burns and pain needs to exist within. So her mother was constantly at her bedside. I don't think I ever saw her without her mother being there, and I saw her daily. She was a very active participant. Of course, she went through a huge emotional roller coaster and with periods of significant depression. But she was an active participant in her management. And in addition to that, there were social workers, psychologists, the palliative care team also came on board, and she was extensively rehabilitated by the physiotherapists and occupational therapists, who are still in contact with her actually on WhatsApp. So over those few months, she had a variety of pain modalities, which included ketamine infusions, various regional anesthetic techniques, morphine, gabapentin, and clonidine. And I'm happy to report that she is currently well, she's thriving. She's very chuffed because she's been fitted with prosthetic legs, which were initially white. And she was quite depressed around that, and she sort of didn't mobilize very well, and she put on quite a bit of weight. But then she got fitted with this skin tone colored cover that covered her legs. And now you can see that more matches her skin tone. And she feels confident enough to wear shorter skirts, and she's mobilizing well and doing really well at school. And then the last patient story to share with you is quite a challenging patient, which has taught me bucket loads. And this is a 12-year-old girl who has degenerative leiomyopathy. And that is a rare disease which has only been described in children of African descent, and is unfortunately terminal, where death usually occurs usually late in adolescence. And she was admitted for functional bowel obstruction, so not really amenable to any kind of surgical intervention, but also because of a severe pain. Now, in children, we always focus a lot on using non-pharmacological pain management strategies. And for her, we used a variety of those. So one of her parents is always by her side. She's fortunate in our hospital setting to have her own room. She is continuously and like fully counseled. She's fully aware of everything that is happening. She has a TV in her room to distract her. We've taught her deep breathing techniques, and she's quite autonomous. So she's extensively counseled, and she's the one that provides consent to any new intervention. Over the course of her, she also, for pharmacological management, was on huge doses of fentanyl, which is a short-acting opiate, and paracetamol. She was on a fentanyl infusion and paracetamol IV. Her gut doesn't work, so she can't take anything orally. So when the pain team got involved, we introduced a PCA pump, so that's patient-controlled analgesia, and so she got a fentanyl pump, which she could press and deliver her own medication. Ketamine infusion, and then for a short period of time, we tried an IV non-steroidal. Unfortunately, she, after 10 days, developed gastritis as a result, so we stopped that, and that has settled. But over time, she developed peritonitis, which was incredibly painful for her, and we really were struggling quite a lot. And so she had an epidural for 2 weeks, which worked incredibly well. And we consulted with a physician in private who does more specialized blocks that I'm not comfortable doing. And we do have the option to expand into, the plan is that he will come and show our team how to do this. And we will perform the block for her if she needs it. But she's since settled really, really well. And she's currently being weaned off her fentanyl infusions. We've transitioned her to methadone, which is tolerating really, really well and has made a huge difference. And that was approved by our PTC. Our PTC in the hospital has also approved fentanyl patches for her at a cost of 3,000 Rand per week. And with this combination, we're hoping that we can actually get her home, because she's now been in hospital for about 6 to 8 weeks now. So really, this case highlights that the massive learning experience for all of our teams. We've used new drugs. There's the potential for collaboration with the private sector. We've gotten advice from experts, but mainly we've employed trial and error, always with her consent. We have a WhatsApp group, which we all use for her, which is dedicated to her, discussing her care. And using hospital processes, we've been able to access drugs that we wouldn't otherwise have been able to access. So we're very encouraged by that. So moving on from patient stories and sharing just the spectrum of pathology that we see and some of the things that we do, one of the biggest challenges that we have is the dissemination of information and being able to maintain patient safety, particularly with high turnover of doctors, such as registrars, especially those that only occasionally interact with children. And so to that end, we've I think, made good use of things like Google Drives and QR codes, which are posted around the hospital. So the first QR code you see there, which will allow you to access a Google document to refer your patient to the pain service, and that can happen 24 hours a day, 7 days a week. And the other QR code there links to a Google Drive, which we can constantly update. And there you'll find our guidelines, protocols, and other information leaflets for patients and for teaching purposes. We use WhatsApp a lot. We've been able to insert most of the links into the description of our WhatsApp group, so everything is easily available and on hand. And I must admit, we don't use EM guidance all that much, but that is probably something that we can explore. But I think it doesn't offer the flexibility in terms of just updating things constantly. But I do think it is a valuable add in terms of just having something available at your fingertips that's widely available to everyone around the country. So I think, if anyone has any suggestions about other things that we could use to help disseminate information, I would really appreciate that. Some of the challenges that we face, I've spoken a bit about personnel and the lack of certain sectors of the hospital to support the pain service. But I think one of the biggest challenges we have is that, it's positive. I say it as a challenge. I mean, it's a great thing, but it also becomes quite challenging in that we live in a multicultural society with 11 official languages and another 2 to 3 unofficial languages. usually Shona, Chichingwe, and Kaps. And interpreter services are largely unavailable to us. There's one interpreter available for the whole hospital and nothing after hours. And it's my experience that patients who don't speak English or Afrikaans are vulnerable to poor pain management. And this is an unfortunate reality and something that we are working hard to address. We're quite privileged in terms of having a range of pharmacological options at Red Cross, but it's still very limited when compared to other settings. And other countries in the global north, for example, who have a range of opiates at their disposal that they can then rotate through, and other devices like, other devices. I'll leave it there. One thing that is notably absent in our hospital is the presence of dads. So when I worked abroad, I was struck by the number of dads in attendance in hospitals, and this is not my experience in South Africa. And I'm sure the reasons are multiple and multifactorial as to why dads are not there. But I can't help but wonder how it impacts acute pain experiences and behaviors in our setting. We also know that our patients have got very low expectations of pain in perioperative settings. And so that really they don't really necessarily advocate, or they lack the agency to advocate for themselves to demand better pain management. And I see that as a challenge. Just a small note, just to expand upon the lack of availability of certain drugs. So we do have limited options in terms of opiates, but I think the biggest challenge that we face is that we face significant amounts of opiophobia. So opiophobia is the fear of using opiates even when they are indicated, as in for moderate or severe pain. And this is particularly in the care of children, and particularly amongst practitioners who work across, adult and pediatric settings. So even though we have limited options, even the options we have aren't optimally utilized. We never send children home on opiates, or we very rarely. I think it's only the palliative care service that does that. And so that also is a limitation for us. And I am very well aware that I'm privileged to work in a hospital that does run opiate infusions outside of the ICU, but most of the hospitals in South Africa don't allow for that. So this is a big challenge for us in the greater South African landscape as well. So this is data from the International Narcotic Control Board, and I just use this to highlight that we fall into the category under other countries, which comprises around 80% of the world's population. And from this, we can see that around 80% of the world's population uses 14% of the world's morphine. And this is not because there's no need in those countries. Often they say that morphine and other strong opiates are severely restricted in over 150 countries, and most of those are in the global south. So this is something that we need to be aware of, and this needs addressing. While the focus or the international global north narrative seems to be very much on the war on drugs and the opiate pandemic, we definitely have a different war to fight. Our war seems to be on pain, and the focus in my context is to reappropriate and reframe that narrative, because I feel that children are suffering needlessly, and so we need to fight this war in a strategic and empathetic way, and we need to arm ourselves with knowledge and create awareness around this. But enough about drugs. This is some of the fun part about what I do. We use, as mentioned before, we use a lot of non-pharmacological pain management strategies. And so we work here with what we do have. I mean, 2 of the patients I mentioned, actually 3 of the patients I've mentioned to you, all have their mothers at their bedsides. We often have grannies as well, very caring grannies or gogos that step in for moms when they're at work. And we have good mobile phone penetration. So we use a lot of videos and music as distraction. So even though we don't have fancy technology like virtual reality, we are able to use a lot of music and play and videos. We don't, at the moment, we're struggling with access to our library, and our library doesn't have a wide range of books, particularly in languages other than English and Afrikaans. So that is something that we really do need to work towards as well. So in summary, we face a significant burden of pain, sure, and we have significant challenges. But for me, most importantly, it's just the lack of will, or the political will, to prioritize pain and child health. But I think that we do have amazing patients and families, and we have amazing teams and clinicians, and we're committed to providing the best care and experiences for our patients. So if you have any ideas about how to do more with less, please do let me know. So I welcome your feedback.
Great, thank you. Been a while since I've been Red Cross. Struck again by the emotional impact of working with those patients. I mean, the trauma is severe, the reward is great. Any questions from any of the participants? One of the things we struggle with in the chronic pain service at Grootskeur is how much of our pain work feels like would be done better at a primary care level. And when you talk about doing more with less, we feel like if we could educate practitioners at primary care levels better, the burden of disease would be lower at our clinic and at our service. I know you've presented work from the acute pain service, but I suppose the challenge is similar. How do we skill up more practitioners around the hospital? And what's your experience when you guys are called in? I imagine it's usually for quite complex patients rather than. I mean, how often do you go, actually, guys? The management of this patient wouldn't have been complex. You could have done it yourselves, or do you find that mainly, your colleagues are quite skilled and you only get called in for the really complex stuff?
I think it varies quite a lot. So certain teams, for example, like burns and pediatric surgery and neurosurgery, they're really, really good at managing their pain or their patient's pain. So when they call us, they're in trouble, and then those patients are often quite complex. But other teams are not necessarily as good, and particularly with this high turnover of registrars. So then it's simple things like, paracetamol is the most frequent drug error in our hospital. It's often underdosing, not overdosing. So often I go and do a pain round and I'm correcting drug dosing or drug scheduling, or changing PRN dosing to regular dosing, or escalating Tilidine to morphine. So often it's simple stuff like that. And that really speaks to just basic levels of education around pain and pain management in children. And so, I mean, that's one thing, but just to tap into something that a lot of our patients are really traumatized by the experiences by the time they get to us. By the time they get to theater, they've been pricked, they've been investigated, they've had, a variety of diagnostic procedures and sometimes therapeutic procedures. And people haven't managed that well. And that's at all levels, from primary to the trauma room, to the ED, to the wards. I mean, every day I'm going into the ward saying, guys, did you use EMLA here? Guys, please don't hold down a patient. How about using a video to distract? So because we use parents not to provide comfort, but to hold their children down. And whereas that would never be allowed in an adult setting. So we really need to do better about doing that piece. And I think that can be done at all levels. And certainly, I mean, some of the patients come to the burns OPD for their dressing changes just because they're a bit better at managing that piece versus at their nearby clinic. So there's so much work to do in this space.
Yeah, it's a real challenge. Romy, any thoughts on the Red Cross acute pain service that you wanted to share? Anything strike you during Anisa's presentation?
No, because it's always gobsmacking to me how much they manage to do with so little. And I think what Anisa's just talked about is some of the key things of, pain management doesn't have to be complicated. It's about doing the basics well, and doing the basics well in terms of seeing the person in front of you, engaging with the human being, engaging with the child and the family, prescribing appropriately in the adult setting, engaging with the human being, who is this person, and treating them appropriately, you know. And I think Anisa's really just highlighted that these are people. It's not nociception, you know. Think bigger.
Agreed, Romy. Sometimes the kind of non-pharmacological interventions feel out of reach as a clinician. They feel either esoteric or like voodoo stuff, or that it takes too much effort. You know, I had a patient wake up from surgery. She was having uncomplicated but surgery, but for very severe illness. It was necrotizing fasciitis, and she was a young mother of two who didn't have a huge operation, but she was very, very sick, and she woke up in agony, and her pain experience appeared to be out of keeping with her tissue damage. And I spoke to her, and we just kind of, before loading her up with drugs that would have altered her ability to think, we spoke to her, and she was so scared. She knew she was at risk of dying, and her kids would be left without a breadwinner, and so would her mother be left without a breadwinner, and she was scared. And I couldn't change that, right? Like I couldn't fix that, but she felt heard, and that changed her pain experience. Like it wasn't like it didn't take any particular skill on my part, but it did take some time. Not a lot, but just enough to kind of talk to him. So anyway, I suppose the message here is acute pain, chronic pain, as from Romy's talk, as from Anisa's talk, there's so much more that you can do that's not drugs, and it's critical. It's a really important part of treating pain. Okay, I'm about to wrap up. Anisa, did you want to say something? Okay, cool. Anybody else, Bex? Right. Guys, thank you so much, everybody, for listening. People come to hospital, people come to see doctors with pain. It's possibly the most important thing we do. So thank you very much to Romy and Anisa for your wonderful presentations that have kind of pushed us and prodded us and made us reflect and think a bit. And we're very grateful for your time. And we look forward to seeing all of you guys next week. Thanks so much.